So can you hear me properly? Okay, thank you. 다 했어. 라이브 스트림 야리 렉지에서. So guys, remember during our tutorial we start discussion about different topics and similar MCQs. Maybe we can continue those MCQs now. Like 5 more cases are left, 5 or 4. So if you think that this is helpful for you, I can give you some more cases and later I will explain your topic. What do you think? Okay, so everyone loves cases. That's good. Life Science 2. Your midterm exam and final exam is supposed to be similar to those questions, and if you find yourself comfortable answering those questions, it means that your final and midterm will not be difficult for you. Give me some. Okay, here we are. Okay, try to read this case number 9. Again, you have 5 minutes to answer this question. I'll try to read it out for you. This is a 60-year-old Caucasian male is brought to his physician from an institution for severe mental deficiency. The physician reviews his family history and finds he has no older sister in the same institution. Their parents are diseased but normal intelligence and no chronic diseases were noted. The man sits in an odd position as though he was sewing, prompting the physician to obtain a ferric chloride test on the man's urine. This test turns color with aromatic ring compound, including certain amino acids, and the green color confirms the physician's diagnosis. Which of the following amino acids was most likely detected in man's urine? 5 minutes to answer this question. Here are option choices. Do you already have the answer? Okay, so can you tell me why do you choose this answer? Do you have a microphone? No? Oh, just a second. Okay, so let's try to provide argument why this is phenylalanine.
Because phenylalanine is one of the 3 amino acids that have an aromatic ring in its structure.
Okay, is there anything else from that case telling you that this is problem with phenylalanine? Is there any other clue helping you to identify that there is a problem with phenylalanine?
Besides the aromatic ring?
Yeah, this is the chemical structure of phenylalanine. You guessed it correctly, that's very nice. But do you know any condition, any disorder which is linked to phenylalanine?
Phenylketonuria.
Alright, PKU. Could that be the case of PKU? Can that be the case of PKU, phenylketonuria?
Yeah.
What kind of deficiency? Can you please take microphone and answer?
So mental retardation, as we consider several mental deficiency, for example, is the one of the indications of PKU.
Okay, so first of all, your answer was correct. This is the condition when phenylalanine is elevated. and you were able to answer the question since you know the structure of phenylalanine, and on the case we had huge clue, aromatic ring compound, and it just gave you information that this person has some amino acid with aromatic ring. From that list, which one has the aromatic ring? It's phenylalanine. Okay, that's very nice, but apart from that we have the case, right? And for that case we have to pay attention to patient age, gender, ethnicity. Sometimes ethnicity can be helpful for you. It's not always helpful, but whenever you see in the case, especially the ethnicity written, it means that this is important. Something is more common in that particular ethnic group compared to the other ethnic groups. Alright? So this is Caucasian male. We have to think about something which is more common in Caucasian people. Then, patient has mental disorder or mental problems, severe mental deficiency. Then, we don't know family history. It means we cannot conclude if this is genetical, what was patient females, brothers, or etc. But we have the information only about the older sister who has the same symptoms, same institution, means that she also has mental retardation. If two persons in one family have the mental retardation or similar condition, you have to think about genetical, right? Genetical mutation, genetical disorder, some metabolic abnormality which follows this pattern. Okay. We don't know anything. There are a lot of information about parents. About patient, right now, what is your patient doing is just an example of abnormal mental condition. And that's it. You have information that he has mental problems, plus about the aromatic ring. Together they give us phenylalanine abnormality, and if phenylalanine metabolism is abnormal, then phenylalanine will accumulate, causing the problem, first of all, mental retardation, some developmental delays. Patient will look pale and extremely pale skin, blonde color, and blue eyes. We don't have description about this patient, right? We don't know how he looks. We know that he is mentally retarded only. Yes? Do you have a question? This is the method, just the method how you can find out which amino acid is abnormal, just to get that information. This diagnostic tool is not that important for you. The most important thing here is, first of all, being able to recognize which amino acid has aromatic ring. That's very nice. Plus being able to recognize what kind of disorders are linked with this particular amino acid metabolism. So from the huge topic of protein metabolism, amino acid metabolism, or different cycles, the most important thing for you are those disorders. You know biochemistry if you can identify disorders, and if you can understand why is that disorder so good or so bad, why is those symptoms, what can we do to help, is there any cure, or can we do something to prevent that. Everything is fixed to the information, knowledge from biochemistry, but not just biochemistry on its own. Biochemistry for medicine. So try to not leave without attention any question or any information regarding disorders. And this metabolism of amino acids and proteins, if they are linked to some disorders, they are important. Try not to miss them. Okay, let's see 10th question. Blood is drawn from a 21-year-old African-American female with severe anemia, and the globin protein is degraded for peptide and amino acid analysis. Of the result below, which change in globin primary structure is most likely to correlate with the clinical phenotype of anemia? To answer this case, you have 5 minutes again. Whenever you are ready, if before 5 minutes, please raise your hand. We already have the answer. Okay, do you have a microphone? Can someone give a microphone? Mm-hmm. I push it for 3 seconds and it will show green light.
I think the answer is B. Valine is meant to...
Which one?
B.
Mm-hmm.
I think it's B. Valine replaces glutamate.
What is the problem, sorry?
Valine replaces glutamate.
Okay. Do you know what kind of disorders we are dealing right now in our 10th case? Good. Yes, very nice. This is a classical presentation, or not presentation, but classical explanation of sickle cell anemia. What happens during sickle cell anemia is the abnormality with the primary structure of the protein, and instead of glutamic acid, patient's hemoglobin is getting valine. And this is the problem. It's a huge problem because later it's causing anemia, right? And a lot of complications. But why is that so bad? So what that glutamic acid is changed into valine? What happens? Why do we care? How exactly? Please? Yes, but why exactly is that? What is the difference between glutamic acid and valine? What happens that instead of glutamic acid we get valine? And valine is what? Is valine polar or non-polar? Non-polar. Glutamic acid is polar. What is the characteristic of polar amino acids? Are they hydrophilic or hydrophobic? Which one? Polars. Are they what? Hydrophilic. Polars are hydrophilics. And now let's think about it. Polar, so hydrophilic amino acid were part of the primary structure, which was in touch with the watery environment close to hemoglobin. Is that right? Around hemoglobin we have watery environment. Everyone knows about it, right? And hydrophilics are tightly attached or have good interaction with the water. So if they are on the surface, that's fine. Structure is unchanged, everything is fine. What happens if instead of hydrophilic amino acid, you get hydrophobic? Non-polar is hydrophobic. Will they interact with the watery environment nicely? No. The structure will dissolve or destruct, it will get damaged. So the primary structure will get damaged. Not get the primary, but secondary and other structures will get damaged, and will try to hide. The hydrophobic amino acids are trying to hide from the water. Yes? Oh, I thought you had something to add. So hydrophobics will try to hide from water, so they will go to the different location, and this movement is something which will destroy the structure of the protein, and that is why you will see sickle cell anemia, not a nice biconcave shape of red blood cell. One amino acid is changed, so instead of one amino acid we get another amino acid. So there is a problem with just one amino acid, and you see the disorder. This is showing you how important is the primary structure of amino acids. based on their characteristics. What do you think? What will happen if instead of glutamic acid, instead of valine, you are getting another polar amino acid? Would that be dangerous? Not that much. Depends, of course, which amino acid, with what kind of characteristics, but if the major and only characteristic is polarity, then you won't see a sickle cell anemia. Okay, good job. You don't know that one yet. I think neither of these. Okay, let's try if you can answer this. No, you can answer this question, I guess. So, we have 12-year-old African American girl who has tall stature, loose joints, and detached retinas. It's found to have a mutation in type 2 collagen. Recall that collagen consists of a repeating tripeptide motif, where the first amino acid of each tripeptide is the same. Which of the following amino acids is the recurring amino acid most likely to be altered in mutation that distorts the collagen molecule? Have you studied collagen? Okay, alright. So I will explain collagen today, but maybe you've heard it from some other topics. The subjects. Yes? Can you repeat with microphone? I'm sorry, I can't hear you.
Is it hydroxyproline? Because it's used for cross-linking of collagen.
But is it that common inside the proline? Oh, inside the collagen. It is part, and it is found in the collagen for sure. But is it repeating itself so commonly? There is the frequency, how frequent you can find the particular amino acid inside the collagen. One will repeat itself very, very commonly. From that list, you have just one which will repeat itself quite commonly, and others are just found in collagen. Who mentioned glycine? Yeah, true. Glycine, right? Glycine is the most common amino acid found there. Of course, you can find hydroxyproline and hydroxylysine parts in the collagen as well. Okay, so it means we have to cover collagen and related disorders. That is fine. I think that's all. Do you have any question regarding the cases? So your questions will be more or less similar, not all. 50% of your questions will be similar to that one, and another 50% will be just direct question asking you information about this or that enzyme, product, regulation, etc. And let's try to briefly revise our connective tissue and fibrous proteins. I guess you partially covered fibrous proteins. You know what is fibrous protein, but you haven't covered related disorders. Try to find what is these related disorders. First of all, what is connective tissue? And this connective tissue, where are they found? So we don't have this soft tissue in the brain. We have soft tissue in the brain and liver, and connective tissue can be found in the other parts. And in so stronger organs, they can look quite strong, and their characteristic is most importantly to have the strength. So these fibrous proteins are created for the strength and mechanical protection of the body. And this characteristic of fibrous proteins can give you information about the characteristic of the organ itself, where they are found. For example, it can give rigidity and strength to the bone, and can give tensile strength since it's found in the tendons, but different types of fibrous proteins, right? We are talking about different types. All of them are the connective tissues, but with different subtypes of fibrous proteins. And inside the blood vessels, skin and lungs, we have slightly different fibrous proteins, and their major characteristic is elasticity. So overall, if you are talking about fibrous proteins, and if you take everything together, not as separate classes, what are those characteristics? Elasticity, rigidity, and tensile strength. This is something which is derived from the fibrous proteins, and secondarily it will be derived to the organ. In the environment of the glycoproteins, hyaluronic acids and proteoglycans, we also have a lot of fibrous proteins which are creating extracellular matrix and creating these different functions of the connective tissue. Two major classes of fibrous proteins we are going to focus on today. This is collagen and elastin. Those are slightly different. Both are fibrous proteins. They are compound of skin, connective tissue, blood vessels, sclera, cornea of the eyes, etc. And for collagen, the most important distinguishable feature is the strength and rigidity. And for the elastin, it's a stretch and recoil. Sometimes we call elastic recoil. So how a recoil is the characteristic of specificity of the structure to go back to its initial initial state. For example, if you take a spiral and try to extend this spiral, how quick and how fast this spiral will go back to its initial state is an elastic recoil. And if it is the same structure as before you stretch this out. Not all the things can go back to its initial state, right? If the compound cannot go back to its initial state after the stretching, then elastic recoil is not high there. Okay? And stretch is basically how far away you can stretch this compound, whatever it is. This is two different characteristics of elastin, and it is not a characteristic which can be given from collagen. Even though those two are the same, not the same, but even though they are in the same group of fibrous proteins. Yes? Yeah, okay, I will just revise them, but I will focus on disorders. Have you taken disorders? But you have to be able then to answer the questions. Yes? I'm sorry, I can't hear. So do you know this information? Okay, who knows this information? Please raise your hand. One, two, three. Okay, that's fine. Who knows information about disorders, osteogenesis imperfecta? Oh, okay, so you covered those topics. Well, that will be part of your midterm exam, not these elastin and collagen, but related disorders. That is why I think it's better to cover these disorders once more. And we can try to revise for you and explain for others. Okay. So these elastin and collagen can be in a different structure. This is like the secondary structure, whereas the globular protein are in the complex one, and they are interaction between secondary, tertiary structures, and you can see their quaternary structures together. This is how collagen looks. collagen chains together, and they are like ropes attached. They have alpha chains, and if you remember, alpha chain was the secondary one. We have alpha chain and alpha helix, beta sheet structures as well. For collagens, where do we find them and what types of collagen is there? We have a lot of different types. It's not mandatory for you to remember all the types, but the type which is related to the disorder is important. So for example, in the extracellular matrix vitreous human of the eye, we have gel-like type of collagen. Inside the tendons, the type of collagen is different. It's like a bundle. And in the cornea of the eye, we have also like a bundle which is created to protect from the and let this light to go through. And for inside the bones, they are fibers which are attached as the not straight line but parallel line. So this parallelity will give it more strength. Okay, amino acid sequence for this collagen. Most importantly is proline and glycine, plus the proline, glycine, and something else. This something else could be other amino acids, but since proline and glycine is the most common one, this repetition will be the most important. Proline and glycine are found most commonly inside them, and it can also create kind of a kink, so the turn where there is the peptide chain facilitates for this helical structure of the protein. What about this glycine? Glycine does not have any special side chain, right? Remember glycine, the smallest amino acid? Since we don't have any special thing on the side chain, that is why it's so evidently found inside the collagen. That is why collagen can be attached to each other, create this triple helix view. So not interference with the arrangement. Someone mentioned hydroxyproline and hydroxylysine. In the beginning, yes, we can find hydroxyprolines and lysines in the structure of the collagen, but it's not that evident. So this structure, glycine XY, is giving you information what kind of amino acids are found there. So glycine for sure. Another, this X can be proline, and this Y can be modifiable. And in our case, it could be hydroxyproline or hydroxylysine, modifiable. Glycine should stay there, like in every single single sequence, which is shown here. Glycine, leucine, hyperproline, whatever is that, but glycine and glycine. Here we have valine as well, so different amino acid. What will repeat itself is glycine. How we can create hydroxyproline, since we mentioned that it's part of the collagen, is by adding something to proline. Of course, source for hydroxyproline is proline. What we do is prolyl hydroxylase is the enzyme which is changing structure, slightly changing structure of proline. What is necessary for this modification? I'm trying to underline that. What is important for this enzyme to function? Prolyl hydroxylase to function, the most important thing is ascorbate. What is ascorbate? Yeah, vitamin C. So in order to get hydroxyproline, we need to have ascorbate. Why is that so important? First of all, this is very important. And why is so? Because if we have deficiency of vitamin C, will that enzyme work properly? They will not. So if you are not getting enough hydroxyprolines, what will happen? Sorry? Yes, scurvy is the disorder by abnormally formed collagen, right? Abnormally formed collagen, and as a result we are going to get disorder called scurvy. We will cover this scurvy later, but now you can see how exactly this vitamin C is important for you. Okay, it's not that important. You know these hydrogen bonds in general, trying to stabilize the alpha helix. That is fine. And there are 25 groups of prolines. You don't need to remember all of these 25 groups. Just the major one and the group of prolines, class of prolines, class of collagens, which are found in different disorders. So the most common type of collagen, which is nice to remember, is type 1. Okay, and where do we have this type 1 collagen? Okay, where else do we have that? Sorry? Okay, let's see in the bones. Then type 1, 2, and tendons. Type 1, 2, 3. They are fibrillar and will be strong. Since they are fibrillar and they are rope-like, it means that their strength is increased. If you try to create a rope, then you are trying to give it special role, and the role is strength. Which structure needs strength in our body? You mentioned that correctly. This is bone. In addition to that, there are other structures which need strength. Some parts of tendons will also need strength. This is the nice picture giving you information about collagen molecule and how this collagen molecule is assembling, creating this rope with the triple helix. And here you can see these heavy regions of the gap. Here is the gap, right? Different gaps will be visible on the light staining. High strength tendon, right? And cornea. Cornea is this small part of our body, and we usually dismiss cornea because it's too small, but still it does need some strength plus tensile strength, so it can be stretchable, and that's why we have a lot of type 1 collagen inside the tendon and cornea. And type 2 is cartilaginous, for cartilaginous structure, partially inside on top of the bones. And for type 3, it should also be strong. First of all, don't forget that it should be strong, plus in addition to that it should have something else, some other characteristic. What is the other characteristic of type 3? It's not as rigid as type 1 or type 2. That's why we have the type 3 in the blood vessels. So not as rigid, and blood vessels are not supposed to be rigid, right? So fibril formating collagens, first, second, and third. And where do we have them? First, of course, we have them on the bones, we have them in the tendon, blood vessel, and cornea. And when you try to memorize which collagens are found in a different organs, please don't think that it's the only type of collagen found there and nothing else. We are talking about majority, right? Majority of collagen inside the bone, let's say, is that type. Majority of collagen is this type, but it does not mean that this is the only one and you won't see any other collagen molecules there, okay? Then network formation, network forming collagen molecules, we have like type 4 and type 7, and the type 4 is I think one of the most important ones, and the very important one is to remember that in type 4 it's found in basal membrane, Why is that so important? What do you think? Have you heard about any disorder with type 4 collagen? When our body is affecting and attacking type 4 collagen? No? Can you speak up, please? Which disease? Ah, you forgot, but you know that there is a disease, right? Yeah, very nice. So there is a disease, autoimmune disorder, when the human body tries to attack type 4 collagen, and this type 4 collagenesis is found majority in the basal membrane. All this basal membrane will be affected, where we have it in the high amount. For example, inside the kidneys, we have high amount of basal membrane, and it will be affected. Alport's disorder is one example, and a lot of different, there is other disorder as well. In type 7, and we are not going to cover these autoimmune disorders in that course. So in type 7, it's not that important. There are no lot of disorders associated with that, so it's not extremely high yield. Type 4 is, so try not to forget about type 4 to be in the basal membrane. And we have another class of collagens which are forming fibrils. Type 9. Most of them are found in the cartilage, and type 12 we have it in the tendons, ligaments, and of course elsewhere, but with a lower amount. Network forming collagens. Our network forming type 4 and type 7. What are they doing? First of all, as the name is implying, they are creating the network, so mesh, where you can add something on top of it. That's why it's called basement membrane. As the name implies, it's a basement for additional structures to go on top of it. Where do we have it? We have it in the different organs. In the first line, all the structure inside the kidneys. Also, we have it in the lungs. So disorder which is affecting kidneys and lungs together is the disorder where we have attack against type 4 collagen. This is type 4 monomers, how they can create meshwork-like structure, basement membrane, perfect area for filtration, right? Since they are arrayed in a special pattern. This is real pictures, the electron micrograph, so not drawing, real visual representation. For type 9 and type 12, they will create fibril-associated structure, collagen, which is found in most cases in the extracellular matrix. Extracellular matrix together with proteoglycans and aminoglycoside. And together with hyaluronic acid, they will create this meshwork of extracellular matrix. And what else is important for collagen is that it's part that they are formed from fibroblasts. What are those fibroblasts? What are they? Are they structure? Are they type of collagen or cell? What is? Yeah, of course, it's a cell where it's responsible the most. Sorry? Yeah, it produces collagen, but what else do these fibroblasts do? In which process the fibroblasts are taking part? What do you know? Is there any special... sorry? Tissue repair, very nice, yes. The special process is tissue repair. For example, healing process. If you want to heal after the incision, after surgery, after trauma, whatever is the problem, if skin integrity, let's say, or blood vessel, organ, whatever is that, integrity was damaged, what will come there to heal that or to help with healing? One of those cells are fibroblasts. How they are doing their job is by creating collagen, right? But this thing here is that fibroblasts are healing by sealing the damaged structure together with connective tissue. Fibroblasts will not be able to seal these damaged areas with their own tissue. What do I mean by that? For example, if there is small problem or death of the myocytes, and there is a defect inside the myocytes, right, inside the heart, fibroblasts will go there to help to heal this damaged area inside the heart, but will heal not with the myocytes themselves, but with the collagen and connective tissue. So it's a healing, true, but healing is not the same as complete recovery. The only difference is there won't be any defect or any dead tissue inside the organ, because it will be changed into connective tissue, but not the same tissue. Does that make sense? Or was it quite long pathway? Make sense? Okay, I can try to put it in a different way. For example, after myocardial infarction, if your patient developed myocardial infarction, what happens with myocytes? Are they fine? Are they dead? Are they changed? Dead, right? Myocardial infarction basically means death of myocytes. So imagine if you have anterior myocardial infarction, so anterior surface of some area in the anterior part of the heart was dead, some part. So you have death of myocytes. Instead of these myocytes, what will come is connective tissue, because fibroblasts will come there in the area of inflammation, and there is always inflammation after necrosis, right? Compared to apoptosis, if there is necrosis of cells, then there is inflammation, and fibroblasts will come in every area where there is inflammation. They'll come and they'll try to remove all these dead tissue, necrotic tissue, and instead of those dead tissue, create connective tissue. So what we'll have later after the effect of fibroblast is, instead of these nice myocytes, you have connective tissue inside the heart. So what do you think? Is that far good? Why it's not that good? It's not the same tissue, means it's not the same function, right? Connective tissues are strong. They will, and they are elastics, but they cannot get the same function as myocytes. For example, they are not excitable tissue. They cannot go and let bypass these electrical stimuli. They won't be part of the electrical activity inside the heart, so pump function of the heart will be altered. But still, it's better than nothing. It's better than the hole inside the heart, right? So thanks to fibroblasts, we get some help. Well, not complete, maybe. And fibroblasts and connective tissue, collagen will also take place in the scar tissue formation. This is the long pathway, how collagen is synthesized. Do you need to know this pathway for now? What do you think? Not really. Well, this was a topic in the beginning, first or second semester. We will touch some of these aspects, the aspect which could be abnormal, either secondary to disorder or secondary to some deficiencies, vitamin deficiency, but for you to remember it by heart is not mandatory for now, and it won't be part of your midterm exam for sure. Disorders will be. Just briefly to see what is that N-terminal beginning of the fibril, and this is C-terminal end, and how there are creation of this triple helix. You can see that here, and cross-link of those fibers, you can see it here. They are assembling from triple collagen together. Degradation of collagen, is that important? Yeah, it is. First of all, the collagen is a strong molecule, so half-life for them is quite long, right? Since it's a strong structure, they will live also quite longer time, and it will be difficult to destroy them. So several years is the half-life, means they live quite long. If you compare this collagen to red blood cells, you can see how strong it is, right? Red blood cells will live up to 120 days, more or less. This will live up to a couple of years. Just keep it on mind. And but we still have remodeling of this connective tissue. Remodeling means that not like whole connective tissue will just destroy itself and will be created from nothing, from scratches, but some parts of connective tissue will periodically get renewed. How it is getting renewed? Secondary with help of fibroblasts, but secondary to different stress, different injuries, different damage which will take place in this connective tissue. There is something which is degrading collagen inside the connective tissue or other tissues. Those are called collagenases. Name is quite easy, right, to remember. What is destroying collagen? Collagenase. Very nice, very straightforward. That's nice. And proteolytic activity is just giving information that proteins are degraded. Collagen is a protein, so protein degradative collagenase will take place in the degradation of collagen in a different part. What are they part of? They are part of metalloproteinases. The metalloproteinase is the name of those enzymes which will work in a different aspect. Here we just talk about collagenase, but there are other functions of metalloproteinases. Why it's called metalloproteinase? Because in their prosthetic group there are different metals, for example iron. This is like creation of the first steps of collagen formation, not mandatory to remember, but we get pre-pro collagen, and from pre-pro collagen what we get is pro collagen by just modifying them. So what happens first is the post-translational modification. Just after the translation, what we get is pre-pro collagen. Then we get its modification. Post-translational modification, alpha aminopeptides, some adding of some proteins, and alpha chain assembly. How this alpha chain assembly is taking place? With these three microfibers. And what we get later from pre-pro collagen is pro collagen. Where does that take place? Assembly of pre-pro collagen into pro collagen. Endoplasmic reticulum. It's important to know because if there is problem of assembly, they will accumulate in endoplasmic reticulum and can cause some abnormalities there. Where we have the process of hydroxylation of prolines and lysines, they also will take place in the endoplasmic reticulum. So hydroxylysine and hydroxyproline is not part of primary structure. You get it later, right? You get it in the endoplasmic reticulum after you get procollagen from pre-pro collagen. Then we need to hydroxylyze residues and glycosylate different parts with the help of enzymes called galactosyl transferase and glucosyl transferase. This is just glycosylation of procollagen. This procollagen or pro-alpha chains then will create this triple helix also in the endoplasmic reticulum. This everything happens in endoplasmic reticulum, and those are post-translational modifications. And what happens is that propeptide will increase in the size with additional post-translational modification and create a final fiber of collagen. But it's not the end. Later we can do some modifications. So procollagen will then leave to Golgi apparatus, transferred to different locations, something which should happen there as well. So our procollagen, where they are secreted, we have to have them not in a particular organ in the end, but we need to have them in extracellular matrix, and we get it by exocytosis. First we have it in the Golgi complex. From Golgi it will live in the extracellular matrix. So well, it's not important how exactly, but with fusion with the plasma membrane, it's just the way how it looks, how it leaves the inside of the cell. And procollagen peptidase will finally remove this peptide bond to free this collagen from procollagen. And what we get from that is tropocollagen. So first we have pre-procollagen, then we get procollagen, and from procollagen what we get is tropocollagen. This tropocollagen is the last one which will assemble itself as the fibers as we know them. Before we go to collagenopathies, I think we can take 10-minute break and we'll continue from collagenopathies. Just the pathway: pre-procollagen, procollagen, tropocollagen assembly. Post-translational modification, hydroxylation of lysyl residues and hydroxyl residue, proline residues, and glycosylation. That's it, what you need to know about the creation of collagen so far. Okay, 10-minute break and let's continue about disorders. Okay, so let's try to continue from the collagen disorders, collagenopathies. What is the most important for us? Well, the before topics is just a revision. Parts of you already know about that. That's very nice, and you have covered that in your previous class, previous semesters. Now, the most important thing is collagenopathies and what kind of disorders are associated. So we have a lot of collagenopathies. Not all of them are so important. Why we have so many disorders and so many small pathologies? The answer to this question is that we have a lot of genes, and the molecule of collagen is quite big. It means there is enough area for mutations to happen. So this enough area includes over 1,000 mutations, known mutation. It does not mean that there is something which we do not know. And the creation of collagen is difficult. First you have to have the correct primary structure, then post-translational modification, hydroxylation, glycosylation. If there is error in any part, then you are going to see disorder. Ehlers-Danlos. It's quite common. It's not a uncommon condition. Extremely stretchability and is the typical characteristic of Ehlers-Danlos syndrome. We have problem of fibrillar collagen molecules in that Ehlers-Danlos condition, and major issue is not with the skin. It's not a problem, right, to have stretchable skin. So what, right? And loose joints. Loose joint can at some point be a problem, but not a huge one. Only important thing here is that it will help you for your diagnosis. You don't need to go after serious, dangerous tests or expensive tests to check collagen itself, but check your patient clinically. If this is something they can do, it's not a special skill, right? Or maybe you've seen patients who can stretch their finger, index finger, or to their palm or something like that. It's not a trick, it's a disorder. Sorry? Is there anyone with that trick? Really? Well, at some point it could be part of physical work, but skin stretchability to that level is not part of physical workout or some other technique or skill. What is the mutation for Ehlers-Danlos? Those are genes. Fibrous proteins are mutated, and those are genes which code for them. Is that mandatory for you to remember those genes? No, not really, but these genes are involved would be nice because it's easy, right? Collagen and genes are involved in that case, and enzymes are also involved, or mutation with that, and mutation which codes for those enzymes which are part of collagen synthesis. Adams is quite common one. The mutation of Adams gene is found in other conditions. That's why if you remember that it can be found in Ehlers-Danlos as well, would be nice and would be helpful. What kind of disorder is that? This is important to know. It's an autosomal dominant. Why it's important? Because we can find it quite frequently. It's not a rare condition. It's not a rare disease. Okay. If their tendons are so stretchable, joints are so stretchable, skin is so stretchable, what can happen is problem, right, inside the joint itself, right? Removal of this joint. And braces are quite commonly used in that Ehlers-Danlos condition. Not all the time, of course, depends on the severity of the condition, but abnormality with the joint itself is very common, since it's so stretchable. But it's not a disorder, it's not a life-threatening condition, and patients are not dying early with Ehlers-Danlos disorder. You don't need to give any special treatment. You just inform them to avoid some the special physical activity, stretching basically, which can cause problem inside their joint. That's it, right? But we have another collagenopathies which is called Osteogenesis imperfecta. That one is dangerous. And we have different types of osteogenesis imperfecta. Now we are focusing on separate types. I think you will focus it in your pathology classes, but what is important here is to understand where is the problem. Problem with brittle bone. So this is the alternative name of osteogenesis imperfecta, brittle bone syndrome. Babies' bones are extremely fragile. Of course, depends on which type of osteogenesis imperfecta is that. If it's extremely severe type, then fetus will not survive. They can get bone fractures inside the uterus. So extremely brittle bone. And if there is slightly milder form, it does not mean that it's an easy condition. But with slightly mild condition, they get easy fractures in the early childhood. So when baby starts walking, it's like 2 years, more or less 2, they start falling down, right? And that is the time when they get easy fractures. Okay. Here you can see X-ray of the baby with the severe fracture. You can see what is that severe fracture of long bone, but it could be found in uterus. Those babies are not going to survive long. What is a clinical feature apart from these traumas or fractures secondary to mild trauma is the blue sclera. You can pay attention to this color. This is quite typical and quite specific for osteogenesis imperfecta. If you want to make diagnosis easier, before you do some genetic testing and checking for the collagen itself with special technique, you can first have the combination of two. Fracture secondary to minor trauma plus blue sclera. Then you have your diagnosis. And this is like taken from real patient with osteogenesis imperfecta. Do you have any question till now? So we covered these two major disorders. In addition to the collagen, we have another fibrinose protein, which is elastin. And if collagen was basically for strength and stretchability, the elastin is for plastic recoil and plasticity of the compounds where it's produced the most. So where these elastin and glycoprotein microfibrils are assembling together, this organ is very easily stretched and back to its initial state. Can you tell me which organ have this function to get stretched and go back to initial state? Which one? Skin? No. Which one? Lungs, right? Yeah, thank you, lungs, for sure. With each breathing, our lungs are changing its size, right? It's increasing, and with exhalation, it's decreasing in the size. This is, we have different characteristics of elastic recoil of the lung, capacity of the lung. It's not our today's discussion, but the thing is, what gives the ability to change the structure to the lung? This is elastin, right? And elastin is found in higher amount together with glycoprotein microfibrils, of course, inside the lungs. What else is that? Where else do we need to have this elastic function? Yeah, of course, blood vessels, right? Especially arteries, not veins. Veins are not so nicely stretchable and going back to their initial state, right? Veins are the reservoirs for the blood. What is keeping blood moving on, basically, is the changes on the size of the arteries, and arteries are mostly important because they have arteries are important to create blood pressure, to keep blood pressure to some fixed level. So this function is given to arteries secondary to its structure, histological structure, which includes a lot of elastin inside them and ligaments. Of course, ligaments are the structures which are all the time changing their position and then going back. Yeah, elastin is also, as you know, a fibrilic protein, fibrous protein. That is why they have something in common with collagen. The only difference here is that collagen is rope-like, right? And it is creating triple helix. It's different from elastin. Elastin is creating tropoelastin in the beginning, and the conversion of tropoelastin will give us finally elastin. But what does that include inside compared to collagen? Collagen included glycine, a higher number. The elastin includes alanine and valine. This is one difference in the primary structure of elastin. And it also has hydrophobic bondage compared to collagen, which had hydrophilic bondage, which was giving it special rope-like distribution to the fibrous protein. Structure of elastin. Here you can see it. Decimal zinc cross links are shown here. This is important just to know that the decimal zinc cross links are found in elastin and they are not found in collagen. We never mentioned the decimal zinc cross links in case of collagen, right? And elastin is insoluble, and it is supposed to be insoluble, right? If this molecule is dissolved inside the water, means it can be dissolved inside the blood, which we do not need, right? It should get the structure and keep the structure. That's why it's insoluble, and most of hydrophobic bondages are found inside the elastin. And of course it's primary. After the translation we get tropoelastin, which is linear polypeptide. Primary structure is that. How many amino acids are found there? Not mandatory. If you to remember, you can just remember that there are a lot of amino acids together, more than a couple of hundreds. And it has small and non-polar ends. Non-polar because it is supposed to be hydrophobic. It has prolines and lysines. Remember, prolines are found in collagen as well, but numbers are not as high as in collagen. Plus, we have more hydroxyproline and hydroxylysine in collagen, and we don't have that many hydroxyproline and hydroxylysine inside the elastin. So the primary structure of collagen is different from elastin. Of course, secondary structure will also be different, but the explanation for this difference lays down inside the primary structure. Okay, you know about tropoelastin. So first is tropoelastin, then we'll have to modify this tropoelastin polypeptide and deaminate lysyl with lysyl oxidase for parts of the amino acids on tropoelastin. Similarly, we did lysine hydroxylation on collagen during collagen synthesis, if you remember. And lysyl side chains will create desmosine cross-links. Neighboring lysine molecules will create together with each other desmosine cross-links, which is specific and special regarding elastin. And that it will produce finally these desmosine cross-links will create in the end this rubbery function of the elastin. Why it's a rubbery function? So you can stretch it and it will go back like a rubber. This is derived mostly from the desmosine crosslink. The desmosine crosslink gives the ability to elastin, in addition to its primary structure, why it's so stretchable and resistant to the stress. Secondary to the stress, elastin is not breaking down, it's stretched. And of course, elastin is part of connective tissue. Here you can see desmosins and how they create this meshwork of rubber. It's not mandatory for you to remember chemical formula for sure. Okay, desmosin crosslinks are catalyzed by lysyl oxidase. This is important. They only, well, I mentioned two enzymes before, hydroxylation of prolines, proline hydroxylase and lysyl hydroxylase. This is important in creation of collagen. And here what is important is lysyl oxidase. But it won't be asked to you finally. You have to know, you already have to know about this lysyl oxidase and proline hydroxylase. Okay, and what happens is that we can destroy our elastin, where this destruction happens inside the neutrophil by the help of neutrophils. And if this destruction is quite high, then we are getting emphysema if there is no additional thing as alpha-1 antitrypsin deficiency. What is this alpha-1 antitrypsin doing? Have you ever heard about alpha-1 antitrypsin? Anyone? So alpha-1 antitrypsin is trying to protect our elastin from degradation. Now let's think, if alpha-1 antitrypsin is not present or deficient, what will happen with elastin? So elastin gives stretchability to the organ, and elastin is protected from degradation by alpha-1 antitrypsin. If alpha-1 antitrypsin is not present, what happens with elastin? Any thoughts? So if something is protective and protection is removed, will elastin stay unprotected? Will that get destroyed? Yes, of course. So if you do not have alpha-1 antitrypsin, if you remove it, or some congenital abnormalities or deficiency of alpha-1 antitrypsin, what you get is unprotected. Now I'm trying to simplify that. Alpha-1 antitrypsin is unprotected, it will get destroyed, and if it is the problem inside the lungs, remember we mentioned that lungs, blood vessels have, and joints have these elastin. So and also liver at some point have this elastin. So if you do not protect this elastin in those organs, and in those organs elastin will get destroyed, what will happen with the organ? Will it have the same stretchability? I think I've heard no. If I've heard no, this is correct. So it won't have the same stretchability. What will happen is that once we inhale and our lung expand, stretchability is, and recoil, elastic recoil is the lung should go back to its normal size, right? If there is elastin, and elastin is helping to do that. We inhale, lung expands, and by the help of elastin, a lung should return to its normal size. If elastin is not present there, lung will expand with each breath, and it will decrease at some point, but it cannot go to its initial state. So lung will stay expanded. Does that make sense? Why is that so? If there is deficiency of alpha-1 antitrypsin and the secondary deficiency of elastin, so directly alpha-1 antitrypsin is not doing anything with the elastic recoil of the lung. Alpha-1 antitrypsin is not helping to it's not helping lung to go back to its initial state, right? Alpha-1 antitrypsin is not doing that. Alpha-1 antitrypsin is just saving elastin for us to do that. from expanding back to the normal size. If alpha-1 antitrypsin is deficient, then elastin is deficient because it will get destroyed by elastinases, etc., metalloproteases. It will be deficient. So once lung expand, it cannot go back to the normal size. It will stay somewhere in the middle. And during our life, every single minute, we are expanding our lung something like 16 times per minute, right? 16, 18 times per minute. So how many times lung is expanding and going back throughout our life? Like lot of time, right? We cannot calculate. Well, someone calculated that for us, but I don't remember the number. It's not important, but we have like such a huge number how many times lung is expanding and going back to its normal size. If elastin is not present there, at some point lung will not go back and will stay expanded like that. But it won't happen in 1 year, 2, 3 or 10. It will happen quite early in people who have disorder known as alpha-1 antitrypsin deficiency. This is a disorder, and those people will develop emphysema. Emphysema is the problem inside the lung when it's too expanded and cannot go back to the normal size, when exhaling is problematic and residual volume of the lung is increased. I think you don't know now with residual volumes and tidal volumes. That's fine, you will study that, but just think about it, that you know that lung is increasing in size and decreasing, right? Everyone know about that. So this is provided, this function, by elastin. If elastin is not there, lung cannot do that. Once it cannot be done with this disorder called emphysema. Emphysema can arise secondary to other disorder, not only by alpha-1 antitrypsin deficiency. The only thing is that if there is alpha-1 antitrypsin deficiency, this emphysema arises in younger people. We are not expecting emphysema in any patient younger than 60 years. So if you see your patient 40 years old, 45 years old with emphysema, you have to suspect alpha-1 antitrypsin deficiency. Of course, whenever we continue our life, we increase times of elastic recoil of the lung, expansion and decrease of this size, right? All the time we are doing it 18 times per minute. So when we reach some older ages, of course elastic recoil will not be the same. That is one of the reasons why elder people have not as good ventilation as a younger one. So if you have grandmas and grandpas 80 years old, 85 years old, of course their elastic recoil in their lungs will not be the same as yours. And so of course you will breathe better and you have the better circulation and blood flow and ventilation than them. But it's not a disorder, it's normal aging. Disorder is alpha-1 antitrypsin deficiency, and you will see it in a younger people. Okay, you have description of emphysema here. Proteinase inhibitor is alpha-1 antitrypsin. It is how exactly alpha-1 antitrypsin is protecting our elastin from degradation. Because elastin, similarly to collagen, will be degraded by proteinase, metalloproteinase. Here you can see how normal alveoli is looking, and on the right side you can see alveoli with emphysema. There are a few areas compared to that, and they are like a balloon which is not filled with the air anymore. So if you ever try to have a balloon and have this balloon at home for a couple of days, you will see how how it looks later, right? Even if you do not remove air from the balloon, it's not as tight as in the beginning, right? So something similar happens with our alveoli. They are not as tight as before. Secondary to this, either alpha-1 antitrypsin deficiency or some other things which will remove or degrade elastin. I mentioned some other things. Cigarette smoking. Cigarette are the stress for our body. It's cancerogen, you know about that. It definitely increases risk for cancer in the lungs and other organs. Everyone knows about it. Nothing new, but the additional problem is it will it will activate metalloproteinases and will help degrade elastin. If elastin is degraded, then elastic recoil of the lung, this expansion and going back to the normal state, will also be damaged. So smokers will develop emphysema as well after a lot of years, but still they are prone to emphysema, similar to alpha-1 antitrypsin deficiency. The only difference is that they won't develop emphysema as early as alpha-1 antitrypsin deficient patients. Alright, we have an additional disorder called fibrillin mutation in fibrillin 1. Fibrillin 1 protein, what are they? They also part of fibrinose proteins, and we have different areas where you can find this fibrillin protein. Most importantly is in the disorder. This is Marfan syndrome. When we have a connective tissue disorder in abnormally produced fibrillin 1 protein, the role of this protein, since it's a part of connective tissue, since it's a fibrous protein, is to get all those structures together and keep them together tightly. So it's giving integrity to the organ. Which organ is that? Human skeleton, the eyes, and especially cornea and cardiovascular system. They are integral, right? So if you have mutation in fibrillin 1 gene, then fibrillin protein will not be folded correctly and you will see abnormality in those organs. What is that abnormality? Is deviation of the cornea of the eyes. Then a skeletal abnormality. Most common characteristic of this skeletal abnormality is scoliosis or kyphoscoliosis. Scoliosis is that abnormal curve of the vertebrae. Okay, and the cardiovascular problems. The most important one here is which one? What do you think? Which one is the most important complication from those organ damages? Sorry? Cardiovascular, of course. Patients are not going to die with eye problems. They are not going to die with scoliosis. It's not that severe, but they are going to die from cardiovascular abnormalities. What kind of cardiovascular abnormality is there? It's not myocardial infarction, right? Myocardial infarction is a condition with blood supply. So your heart is not getting enough blood. This is different. What is here is the structure of the heart. We have cardiac myocytes mostly in the heart, plus we have connective tissue in the heart, right? Where exactly do we have connective tissue? Any thoughts? Let's try to think about anatomy of the heart and histology of the heart. Where do we have connective tissue? Is there anything in the heart where we have most of the connective tissue? Small part, teeny tiny. What? I'm sorry, can you speak up? Outer layer? Outer layer, yes. Okay, that's true, but it's not that important for us because it's not giving any structure. It just surrounds the heart, right? And it's not keeping the structure of the heart integral as it is. It can also be abnormal and get inflamed and secondary cause the problem, but not in patient with fibrillin abnormality. So try to think about the structure of the heart. Some connective tissue inside the heart is there something inside the heart which is opening? Okay, good. Opening and closing, right? Valves are attached to something. What are those something which are attaching valves? Sorry? Yes, so chordae tendineae. What is this chordae tendineae? This is connective tissue, right? And where these valves are located are connective tissues. Valves are connective tissues themselves. So if you have connective tissue abnormality, then these valves will not be the same as in the healthy person. So you can get mitral valve prolapse. Of course, not you, but your patient can get mitral valve prolapse. And a problem is the huge artery, which has a lot of connective tissue inside. Can you mention any huge artery in your body which has a lot of elastic tissue inside? Aorta. Everyone mentioned that, right? Yes. So aortic problems are also typical for patients with fibrillin 1 deficiency. This is aneurysm formation. Do you know what is an aneurysm? Aneurysm is a ballooning of the vessel. So if my microphone is the aorta, let's say it does not look like aorta, but the top part of it can work as an aneurysm. So ballooning, something extending from the wall. If the integrity of the connective tissue is not provided correctly, it will balloon with the pressure. And if any of you have ever owned a car, you know this ballooning can happen in the wheels, right? Which are filled with the air. With some pressure, then at some areas you can see extensions like a balloon, and this is called aneurysm. Our body hates aneurysm. First of all, it can rupture, and this is fatal if it ruptures. Not all the time, but it's very, very dangerous. Plus, it will interfere with circulation at some point, but this is a different story. So those patients have cardiovascular abnormalities, and those are the cardiovascular abnormalities which are present in this patient. Not arrhythmias and not myocardial infarction. So microfibrils are not abnormal here. What else? Oh, and the people with fibrillin 1 deficiency together with Ehlers-Danlos loss and osteogenesis imperfecta will have loose sclera. This is classical picture of someone who has fibrillin 1 abnormal mutation. It's called Marfanoid habitus. Why Marfanoid? The disorder is called Marfan's syndrome, and Marfanoid habitus is that one, but it does not mean that only Marfan syndrome patient will develop these phenotypical features. So Marfanoid habitus, typical for Marfan syndrome. What is that? Eye problem, deviation of the sclera. Then long arms, extremely long arms because of misfolded fibrillin 1. Scoliosis, which is not shown, I think. Yeah, it's not shown. And inward incavation of the sternum. So these sternum of those patients are pushed inwards. So when you see them, it looks like there is a hole inside their chest, since everything is pushed back. Then what? Signs and symptoms. Extremely short, long legs and extremely long fingers. Sometimes it's called arachnodactyly because their extreme long fingers can look like a part of how it's called in English. Arachnodactyly. Arachnoid is spider. Thank you. So it looks like a spider because too thin spider legs. It's too thin and too long. Okay. Their fingers plus their legs compared to their torso. What else? They have flat feet. Nothing specific, but you can find this one for your patient. And abnormal heart sounds in physical examination. Abnormal heart sound because those valves are not working. We have some problems, and with that problem, prolapse. Let's say the cardiac sound was, you haven't studied it yet, but cardiac sound will be abnormal. Okay. What else? Those are the most characteristic features. When you just look at the patient, you'll be able to recognize. So here is that one. Arachnodactyly, extremely long and thin fingers. Thumb is so long that it is crossing everything above the palm. If you can try, it's not necessary to have Marfan syndrome, and I can assure you none of you have Marfan syndrome here, no worries, but it is one of the symptoms. A lot of sportsmen have Marfan syndrome. If they are not a lot of, but some of them have it, because if sportsmen are tall, extremely tall with tall legs, they are supposed to be like that. So Marfan syndrome side effect can be used as a good effect, and very famous person with Marfan syndrome. Can you recognize him? Sorry? Yes, US president, right? US president with the Marfan syndrome, commonly known one. So I can ask you one question, and I think you have an answer for that. I haven't mentioned anything about mental retardation. What do you think? Do people with Marfan syndrome have mental retardation? Definitely no, right? I have included extremely popular, famous US president. He was extremely smart, and of course, it will help you to remember that people with Marfan syndrome don't have any mental retardation. Why it's important, you will see later, because there is another condition with Marfanoid feature, but with mental retardation. So for differential diagnosis, it can work. I guess that's it. Yeah. If you have any question, please feel free to ask. No questions? Yes? No? Okay. If there is no question, then I guess you are free. We have a lecture next week. We start another topic, which also will be part of your midterm exam. This topic will be part of your midterm exam, especially disorders, not how you create collagen, not how you create elastin. It was for your revision and to see where exactly do we have problems. But that's it. Scurvy was not covered here, so if it's not part of the presentation, it will be part of your midterm exam. Someone asked me about this presentation. Can you please come here? I will send the presentation if you don't have it. Plus, someone asked about these questions to practice. Please come here and I'll try to send this file to everyone who wants that. There are 2 questions left which we haven't covered because it's related to today's topic, so it'd be nice if you check it at home as well.